It is a great pride and immense pleasure to introduce one of the senior most orthopedic surgeons of India, past president of the Indian Orthopedic Association, and a legend in orthopedic oncology, internationally well known, and my dear friend of 4 decades, Professor Dr. Mayilvahanan Natarajan of Chennai. During the next 25 to 30 minutes, Dr. Mayil will hold our hands and walk us through his journey of the last 35 years in orthopedic oncology, a specialty which was non-existent before he began his humble endeavors and which today is a full-fledged super specialty in our country. Over to Dr. Mayilvahanan. Please share your screen and enlighten us with your talk.
Good morning, everyone. I'm thankful to Dr. Prakash as well as the organizers of the conference for having invited me to give a talk on this occasion. I'll be talking on limb salvage surgery in bone tumors by custom megaprosthesis, my lifetime's work on bone tumors in the past 32 years. I'd like to dedicate this talk to my parents, my gurus, and the Lord Almighty for having blessed me to do this work and propagate this work. If you are thinking of primary amputation for a malignant bone tumor, you belong to the last millennium. You are not fit to do orthopedic oncology because the current work is now all limb salvage in this new millennium. There is no role of amputation at all. Now, I will be now showing how limb salvage by custom prosthesis is better than the best method available in the management of bone tumors from my own experience. In the past 32 years, I had the opportunity of operating on 2,250 cases wherein the tumors have been resected and replaced by different types of custom prostheses in different parts of the body. The work was essentially carried out at two places, namely the Regional Cancer Institute in Adyar, as well as the Government General Hospital, where I was attached to for 32 years. The private hospitals are the Apollo Specialty Hospital in Tenampet, as well as my own orthopedic hospital. The first case was done in the year 1988, and the work is still going on, and I've analyzed the cases done up to 2020, which includes the number of 2,250 with a minimum follow-up of 2 years and a maximum follow-up of 360 months. The majority of the patients were in the age group 15 to 24. That means they were young adults, and the tumor sites are the common tumor sites: the distal femur, the proximal tibia, the proximal humerus, and the proximal femur take up the majority of the anatomical sites, but no other region was spared, namely distal radius, distal tibia, shaft of femur, humerus, and all the others are the different parts. Histopathologically, majority were osteosarcomas. Recurrent giant cell tumors, chondrosarcoma, metastasis, Ewing sarcoma were all the other types of tumors which have been operated upon. I'd like to place on record the appreciation to my academic and genetic father, Professor Natarajan, who in the year 1978 excised the fibrosarcoma of the ileum and replaced it with the silver prosthesis. He made a process of silver, and then he put in some screws and tried to support it. Obviously, within a short time, it was infected and it was had to be removed. But the principle caught on, wherein metal can be used to replace large segments of bone. Not the normal segments, but large segments of bone. This was my first case, which I operated at the Cancer Institute. A middle-aged lady, giant cell tumor of the distal femur. The CT scan showed the cortical breaks preventing any sort of curettage and cementation. So I decided to resect the tumor, and this was the blueprint diagram made for making the prosthesis. The dimensions have to be given, the length of resection, the diameter of the bone, and the intramedullary comb, all had to be given to the man who made it. and the prosthesis was given. This was the tumor which was resected, and the prosthesis was placed in situ, and this is the lady you can see here. 10 years down the line, she develops a stress fracture of the intramedullary stem. However, she was still continuing to walk, and she was put on a weight relieving caliper for 1 year because she did not want any surgery to be done. And it sort of remodeled, and she was able to continue walking without the brace. And even today, she walks with a slight limp. But however, she's a happy customer with no issues further. This is a recurrent giant cell tumor in the proximal tibia, wherein you can see the lytic areas as well as the joint which has been collapsed. And so we decided to resect the proximal tibia. The anterior tibial vessels are ligated, the lateral popliteal nerve is dissected, and the proximal tibia is excised in mass. And we ream the femur and tibia, prosthesis is seated with cement. Now you can see the long-term 30 years follow-up, no revision done. Obviously, the X-ray shows evidence of loosening, but the patient is not having severe pain and he is able to walk. So I have not thought of any revision for him. When and if he develops pain or if he develops a fracture, then there is an indication for revising the prosthesis. Now, this is a osteosarcoma proximal femur. The rules of the game are always the same. The chemotherapy is given, they take it up for surgery, wide resection, including the muscles, and then reaming and seating the prosthesis as well as the acetabular component. You saw the gait, it was a near normal gait after 20 years, and he's doing well. This is a tumor in the proximal humerus, wherein you can see there's no cortex, the whole thing is gone, so no way of doing any curettage. So the whole was resected and replaced with the metallic prosthesis of the proximal humerus. Now, obviously, he cannot lift his shoulder above the head, and this is the amount of rotations he'll be getting. But still, he is able to use his hand normally for all practical purposes. He is able to lift weights up to 5 kg, and he can drive a vehicle. Now, this is a chondrosarcoma of femur in the shaft of the femur. And after a biopsy taken up for surgery, you can see the operative pictures. You can see the layer of muscle which has been laid open, and that is the tumor-bearing bone. And then the head is being dislocated. You can see the head there. That is the part of the tumor is coming out, and now you can see the whole tumor with the bone. So because of the fact that the remaining bone, if you leave behind remaining bone, will not be able to mechanically hold the prosthesis, I decided to do a total femoral prosthesis with the head and head of femur and the knee joint. And that is the process after being seated and closure and the post-op. And then you can see he's walking independently with a walking stick for more than 2 decades. Similarly, an Ewing sarcoma of the humerus, after giving this, you receive 12 cycles of different chemotherapy, and after 6 cycles, I take them up for surgery, and that is the bone which has been resected. Both the humerus and the elbow have been dissected, and this total humeral prosthesis with the head of humerus and the elbow joint. So it's been seated, and he is able to do his work. You saw the movements, and he is able to lift weights up to 5 kg. He is able to drive a 2-wheeler, and other than lifting heavy weights or lifting his arm above the shoulder, he is practically a normal man and a satisfied patient. Osteosarcoma distal tibia, the Western world believes that you have good prosthesis, so you might as well remove the limb and then put in a prosthesis, but I decided otherwise. After chemotherapy, I devised the prosthesis of the distal tibia with the ankle joint and the talar component. You can see that here. And after resecting the tumor, the prosthesis is placed in the distal tibia. The top of the talus is shaved, and there are screws which connect the top of talus with the prosthesis. The movements which are obtained will only be about 20 degrees of dorsiflexion and plantar flexion. However, the patient is very satisfied having walking on their own on limb. So that is the distal tibia prosthesis. Other rare sites like the distal radius, osteosarcomas of distal radius, where we can dissect the distal radius and put in a biaxial hinge distal radius. You see the prosthesis here, that is the tumor coming out, and then we have to select. The lower end of the ulna, if it is not dislocating, you can keep it there, or it can be excised depending upon the condition. And that is the amount of palmar flexion and dorsiflexion, not 90 degrees, but then it's only 20 degrees of dorsiflexion, and there's a palmar flexion. Here, there's a post-op X-ray, and you saw the clinical photograph. This is a man with multiple exostosis with a chondrosarcoma of the distal humerus, and no chemotherapy is needed in these cases. So we resect out the tumor and then put in a prosthesis, and that you see the patient. And that is the post-op X-ray, long-term follow-up, no loosening, no revision. They're quite satisfied. If you take care of the process, a little bit of care is shown to the process, then they last a very long time, without a doubt. Intercalary process for lesions in the mid shaft of the humerus. After giving chemotherapy, we can resect the middle third of the humerus. And if you have enough bone proximally and distally, then we can do what is known as the intercalary process with the intramedullary component, wherein you can put in the intercalary piece and then the intramedullary component goes inside the bone. So this is the part excised. And then once again, this boy developed loosening, which was revised. Aseptic loosening. We put re-cement and then put it back once again. And then once that was done, it went on for quite 14 years. And this man can lift weights and he uses his right upper limb near normally. Nearing the joint, if the patient cannot afford the prosthesis, the indigenous prosthesis is very, very cost effective, and compared to the imported prosthesis, about 4.5, 5 lakhs. Whereas the Indian prosthesis works out to about 1 lakh, the titanium one, and 75,000 or 50,000 for the stainless steel. People who cannot afford the bending knee, who have a lesion like this, then it is possible to do the intercalary process where you resect the bone and then you put in a prosthesis. This is like the Enneking turn-up, turn-down graft, wherein the knee is now arthritis. The patient will not have a bending knee, but this process only costs about 10,000 rupees. So the patient does not have to lose the limb because they do not have money to buy the prosthesis. So even for the poorest of poor, there is an alternative in this method of treating the patient. Now we come to pelvic tumors, periacetabular lesion. This is a chondrosarcoma of the pelvis in the periacetabular region. Obviously, this will require resection at the pubic symphysis, and you can see the proximity to the proximal humerus. So the head of femur has to go, and then you have to cut the acetabulum at the sciatic notch level. So that is what is done. And then there is a process known as the saddle prosthesis, which has a U which sits into the ilium at that point above the acetabulum. And this goes into the proximal femur like the femoral prosthesis. Obviously, it will not move like the normal hip, but there's a rocking movement in the pelvis, and this is how the patient will be able to sit. Not at 90, but the patient will have at least 45, 50 degrees of flexion at the hip and 90 degrees flexion at the knee. So with this, the instability is not there, and the shortening is not there, and the patient can move around and sit in the car, drive a vehicle, all those things he can do. Currently, with 3D imaging, it is possible to make a pelvic prosthesis based on the 3D images which we obtain. We can send it and have a prosthesis made for the pelvis which replicates the bone which you are resecting. If you are resecting the whole of the hemipelvis, also it is possible to make a prosthesis and then seat it with the pelvic bone. And this is what we did in one patient. So almost 2/3 of the hemipelvis was removed on the right side, but we had adequate methods to make it, and then we put in the process. Now he was all right, but then he locally he was okay, but he developed metastasis even after the chemotherapy was given, and then he passed away. Till now, we are doing only a scapulectomy and then leaving behind portions of the glenoid or the scapula. However, we felt that there must be a role which is being played by the scapula. So this is now, we now made a scapula prosthesis and then attach it to the humerus also like this. And we have done only about a few cases, so we are just following it up. So only time will tell whether this is better than the cases which had a scapulectomy per se. So in the following years to come, I will be explaining the follow-up of these results. But it's already been done now. Now we have heard of terms like metachronous osteosarcoma, synchronous osteosarcoma, which are very rare. But custom process being done for both sides is still rarer. So I'm reporting a few cases wherein a patient has a osteosarcoma proximal tibia, when we revise it, excise it, and put in a prosthesis. Now, after the chemotherapy is over, 2 years down the line, the patient develops another lesion, the proximal humerus. And once again, biopsy proved it to be an osteosarcoma. So once again, we repeated the chemotherapy and excised the proximal humerus and put in a proximal humerus patient, prosthesis. The same patient, diagnosed the same on 2 different areas. This is the metachronous lesion, wherein the proximal tibia as well as the proximal humerus are working well, and the patient is a very happy person. So these are all very, very rare cases. Synchronous. Synchronous osteosarcoma itself is rare, wherein you find a lesion both in the proximal tibia and the distal femur, which is osteosarcoma. So after giving chemotherapy, we devised a prosthesis, both the distal femoral and proximal tibial prosthesis, and then excise the tumor and then put it there. But the only thing is that there is no way we can control the knee. So the patient has to have a orthosis with a knee brace, with a knee joint, which will give the support. Otherwise, the whole thing will buckle and he will fall down. But this is better than removing the limb, you see. So herein we have removed the distal femur proximal tibia, put in the process. And he is on a knee brace. Several myths and misconceptions have cleared up in the past 2 decades. For example, is the size of the tumor, if it is very big, is it a contraindication for surgery? People always thought when you see a massive tumor like that, you should remove that. But then it's not necessary. Angiogram showed that the vessels are far away, and then I excised the tumor and then replaced with the prosthesis. And you see, this man is not able to even abduct his shoulder up to 70 degrees, but he is quite comfortable and happy, and there's no revision been done. People say it is a spacer. Yes, it is a spacer. But see the quality of life which he has had for so long. Pathological fracture. Even in my series, I thought if you have a pathological fracture, there's tumor spillage and there's the tumor cells in that area. And so I was doing amputation. Then I thought, you have to extend and see what happens. So I thought, let us now give chemotherapy and then do a resection and then put in a process and then see what happens. See, the consent is obtained from the patient that it is safer to remove the limb, but then if you want, we can try this. So I tried this and then realized that the patients were not dying as I expected them to die. And there was no local recurrence also. So that means chemotherapy works and the tumor spillage, all these things can be excised. So you have to be more aggressive in your resection. And if you put it, there is no problem from the osteosarcoma cells. So this patient was doing well for 25 years, developed a loosening, and then I revised it, and now she's doing well. Pediatric age group, once again, because if you have a young patient and you do a prosthesis, then there will be limb length discrepancy. Yes. How do you tackle the problem? Now we have what is known as a lengthening prosthesis. So you put in the prosthesis, and every year you decide how much this, if you put in a key and then jack it up, there will be lengthening of the prosthesis. So I did that, and then we did 3 lengthenings. Now, after you get about 8 to 10 centimeters, then it is possible to remove the process, put in another new process, and then you can have still more lengthening, so that the patient at the end of growth at 20 years, it is possible to have a near normal length of same lengths of both the legs. Once again, experience has shown that initially, if there was an infected biopsy scar, I used to do an amputation. Then I thought, let us see what we can do. So even if there's a tumor which is fungating or something like that, you can take out the tumor as a stage procedure 1. and then put spacer there and then close it and then see whether there's any remnants of infection 3 months down the line. You do a CRP, blood culture, and everything is safe. Then you can take it out and put in a prosthesis. So we are not writing off the limbs, and we are finding more ways of saving the limbs more and more. Now, what happens to overall functional outcome in these cases? You can see that the MSTS score is good outcome for that. We have anatomical regions and diagnosis split. So there are several papers which are coming up wherein we are talking about different areas, different diagnosis and all those things. But to get an overall idea to the people, I thought I should tell this. Whereas the knee and proximal femur, the outcome was excellent. The outcome was good in the proximal humerus. So that is why people criticize it, saying that the proximal humerus acts only as a spacer. But whatever it is here, they have their limb and it's a sarcoma. As a man involved in this work for 3 decades, I must admit that large implants are always subject to failure in the long run and will invariably require revision. Now, we orthopedic surgeons do not think we are God. The man who's doing the liver replacement and that heart replacement and think, they don't think, oh, the man be alive for 10 years, 20 years. As long as he's alive, the quality of life is so good. So in that way, please don't think orthopedic surgeons are gods which are going to give a solution once for all throughout the life, which is going to last for 50 years. Don't have this egoistic feeling, and then you continue doing your work so that the life of the patient for which they are alive, they have a very, very good quality of life. Now, looking at long-term survival with time, the prosthesis, if it fails or it becomes loose or you do a revision, then it's called a failure. But you have not removed the limb. You can go ahead and then replace the prosthesis. And so now I'm now facing the revisions of all the patients which are coming. And all of them are immensely happy. And they have been happy so long, and they'll be happy for the next 25 years after the revision. Now, what happens? This is a very common occurrence where you have a pathological fracture. My orthopedic colleagues, they go and fix it and then take a biopsy. Then the biopsy comes an osteosarcoma. Now, initially, once again, I thought, okay, now this is going to recur locally, so I amputate it. Then I thought, no, let us see whether it is possible to save the limb once again. And so after chemotherapy, I excised it once again, put in a prosthesis. And surprisingly, there was no local recurrence. So I said, okay, even a case which has been buggled up like this, it is possible to save the limb. And the patients are immensely, the whole family is immensely there. And then what you put in, of course, can develop a stress fracture. And if you had the stress fracture, you have to revise it. Because you're putting in large processes, the stresses are more and stress fractures are common. But it's a part of the game and you'll have to tackle it as it comes. Proximal humerus, I told you, it will produce a little bit, you will think that it produces a downward subluxation. But in this case, you will notice it produces upward subluxation, so that it looks a little bit grotesque in the upper side. Now it's very mild. You can put a shoulder, leather shoulder support and cover it up under the elbow, under your dress, so you don't have to do anything like this. If it's very bad, of course, you have to go and revise it. But then most of the cosmetically, we are not that much concerned like the others. Now, this is a pre-op case with a pathological fracture, sarcoma, chemotherapy, excise, put in a prosthesis. We don't know the reason for the aseptic loosening. Sometimes they last for a long time, but this case, after 9 years, develop aseptic loosening. And then once again, when all the counts are done, you take it out. And this time you have an option. If the process is good, you can use the same process and re-cement it. Or if you want, you better change it because it's already 10 years old, you can change it. So you have 2 options, and then you have to leave it in situ, and the patients are quite comfortable and happy. Because these are rotating hinge, the distal femur initially was a constrained hinge, then it became a rotating hinge. It can break inside the rotating component, and then it comes out like this. And here we can go in and change only the rotating hinge component. You don't have to revise the whole femur or tibia unless there is a problem. You change it and then you can put it back, and the patients are comfortable. I told you about the aseptic loosening in the intercalary process. You see the amount of lateral rotation. So you're taking it out and then put in the intercalary process. Once again, re-cementing the loosened process. Dislocations, this can happen because you exercise quite a lot of muscle and things like that. So The bipolar dislocates, you try a close reduction and then immobilize for 4 weeks. Otherwise, you do open reduction. Peri-prosthetic fractures, the prosthesis and the intramedullary compound are all right, but then they develop a fracture at the tip, and then comes in your locking compression plate with some wires or bands, you can tie it and then you can fix it. Local recurrence. See, in my initial 10 years of work, whenever there was local recurrence, I used to do an amputation. Then I thought, let us do some research. Then once you have local recurrence, you open it. And then after chemotherapy, you once again go and excise the tumor. And then if the process is all right, leave the process. Or if the process is not all right, you change the process. And then you see, and then surprisingly, they were also doing well. And there was a good 50 to 70% chance that the local recurrence kept quiet and then became all right with your chemotherapy. Once you develop local recurrence like this, which is involved the soft tissue, then it is better accept reality and then tell them the patients and the relatives are happy. They have also struggled with the limb for so long. You also struggle with the limb. And they do accept amputation if you're doing it after 10, 20 years down the line. If you have a metastasis, it is not a contraindication for not doing anything. You can do the primary surgery for the proximal tibia, and if you have a good team, you can do it the same sitting, you can go and do a lobectomy. You call your cardiothoracic surgeon, once you close, the cardiothoracic man takes over and does an excision of the lobus. And you see the patient all right. Or you can do it as second stage. Or you finish it and then send it to him, and then your cardiothoracic man does it. You see, metastasis is very common. Whenever you have metastasis, don't think that if he has metastasis, so write him off. Don't judge anyone. Don't judge anything. Your job is to keep the patient alive, keep him comfortable as long as he's alive. So if you have a metastasis, you do your primary procedure for the tumor and then do an excision of the metastasis. Same sitting or another sitting, depending upon your facilities available. Once again, late infection happens and the patient comes with infected prosthesis. First 10 years, I was amputating. Second 10 years, I said, no, take out the prosthesis, debride, put in a spacer, and then allow healing to occur. Minimum 3 months, maximum 6 months, you wait patiently. Don't be in a hurry. Let the ESR, CRP come down. Let your infectious disease man exhaust all his antibiotics. Then you go and do it. I will prefer 6 months waiting period. Then you do it, nothing happens. The patient become all right once again. And then they have another lease of life. That going through period is very difficult, but then you have to convince your patient. Now, large processes, the titanium, stainless steel, whatever you put in, they have some reaction. And there is no metallosis. You see this black thing. Whenever you're going to revise it, you have to take it out. And then you send it for culture. And initially, I was worried whether this is carcinogenic, whether this can produce any malignancy. It did not produce and has not produced anything. So, thank God, everything is fine. Now, all these have been used, the indigenous processes, and I have compared this with the imported processes in the various sites. And by comparison, I find they're all, they reach up to the international standards. So no one can blame and say, your processes is bad or something like that. I just show 2 sites, the distal femur. You see this publication 95, 10-year process 67, 85. And compare with that 10 years process, ours series 76, 88. So it compares well with the process. So problems are same everywhere in the world. Take the next comment, say the proximal tibia. In one publication, I just compared it to show that our experience with the international experience of the international prosthesis, they compare and augment very well. So we have reached, India is not a developing country anymore. India is a developed country. And we have our problems. Like we have problems in other developed countries, we have our problems, that's all. I would like to finish by saying that long-term clinical evidence is not 32 years I have seen, worked, and I have to follow up every case till date. There is no standard of care in limb salvage. There is no doubting it. It's not experimental. You should do it. And currently, out of the 28 states in India, 20 states are doing this work. And out of the 8 union territories, 3 union territories are doing the work. So I've gone right throughout all the places and then talked in so many meetings and then convinced people that they should do it. And The whole of India in the next 5 years should be amputation free. Limb salvage surgery is a safe and effective method, and custom prosthetic replacement after tumor method is better than the best method in the management of malignant bone tumors, in my opinion. I would like to finish by a prayer from inability to differentiate the benign from malignant, from too much zeal for surgery and contempt for chemotherapy and radiotherapy, from considering incision before planning, excision before biopsy, and amputation before salvage, from creating disability when we can offer mobility. Good Lord, deliver us. Thank you, Dr. Prakash, and thank you, the organizers of the meeting.
Thank you very much, Dr. Mayil, for this outstanding talk. You can stop your screen share. There you go. Yes, I am extremely proud to say that this is one of the most outstanding talks which made the hair on my hands stand up with the adrenaline rush. I must salute you, Dr. Mayilvahanan, for this wonderful talk, and I'm sure that all the young surgeons listening to the talk today will have an important carry-home message to take home, that next time they see a malignancy in a bone and a limb, they avoid all the pitfalls that you have mentioned in the last all-encompassing slide. Thank you very much, Dr. Mayil. Thank you.